Hi, good morning. I'm Dr. Townsend, and I'm going to go over a brief introduction to lipid management for CMN 572. Remember, lifestyle modifications are always first recommendation and continue even with the addition of lipid-lowering medications. Now, I think sometimes we take for granted what exactly are lifestyle modifications, that our patients understand what we're talking about. So I want to be specific with you. We want to tell our patients not to smoke if they do smoke, to engage in regular physical activity about 30 minutes a day for at least 5 days a week. Want to encourage them to do more if they will, but at least that much. To eat healthy foods. You want them to eat high in fiber, low in fat, low in sodium, and eat more fish, specifically, obviously, oily fish like salmon, tuna, those kind of things. And try to cut down on cheeses, junk food. Stay away from that. That's particularly important with kids. We're getting into problems with overweight generation coming along. Manage their blood pressure. Try to keep the glucose under control. Focus on keeping lipids managed. So those are the lifestyle modifications. Just get active. Cardiovascular risk calculator. What is their 10-year risk of ASCVD? The cardiovascular risk calculator is become pretty common. This is what's standard. You'll see out there used a lot. There's also the Framingham risk calculator. It's an older one. It does not encompass stroke risk, but it's still used. So you'll see one or two of these used in practice. The cardiovascular risk calculator, some think that it may overestimate the risk, but anyhow, so that you know, these are what you'll see out there. Probably cardiovascular risk calculators used more often. Atherosclerotic cardiovascular disease, ASCVD risk calculator. The cardiovascular risk calculator estimates the 10-year primary risk of ASCVD. ASCVD is now defined a lot more broadly than it used to be. It's non-fatal MI, coronary heart disease, stroke, and now peripheral artery disease. The purpose of the cardiovascular calculator is to estimate ASCVD risk within 10 years. And in 2013, the ACC/AHA guidelines recommended that patients be treated with high and moderate intensity statins if their ASCVD risk was greater than or equal to 7.5%. This is very important. You need to know this. So if you're going to treat them with high or moderate intensity statins, if their ASCVD risk is greater than or equal to 7.5%. So obviously you have to use the calculator. So you'll want to load that on your phone or whatever you're taking to clinic. Okay, the people who need a statin. 4 statin benefit groups. Individuals with clinical ASCVD, individuals with primary elevations of LDL-C greater than 190 milligrams per deciliter, and there's some thought that approximately 10% of the population may have LDL-Cs above 200. So pretty significant. Individuals, the next one is individuals with diabetes, age 40 to 75 years, with LDL-C that is 70 to 189 milligrams per deciliter without clinical ASCVD. The 4th one is estimated 10-year ASCVD risk of greater than 7.5% of those age 40 to 75 years with LDL-C that is 70 to 189 milligrams per deciliter without ASCVD or diabetes. Okay, so you've heard who's supposed to be these populations that need a statin, the benefit groups. You want to look at these factors to consider when you're talking to patients. Adherence and lifestyle. So we're back to lifestyle again, and are they going to take the statin if you prescribe it for them? We'll talk about that more later. Statins tolerance, that's also something. The control of the risk factors that we've already mentioned. Stop that smoking, get out and get active, eat healthier. That's easier said than done, but trying to model that for our patients and talk to them, have a real honest dialogue. But where it says here, the clinician-patient discussion regarding potential risk and harms and patient preferences, you have to really have an honest discussion with them about this. And, that helps with the adherence, because you may prescribe something, but they may not take it. So be honest and upfront about where you are with things with the patient. Percentage of LDL reduction, we'll go over that depending on if it's a high intensity statin or moderate intensity. There's a different amount of the reduction that you'll see. You'll need to know this. And monitoring the response to therapy. So, and there's optional interventions to consider. These are other medicines, if and when you need to add on, or if somebody doesn't tolerate something, or if they need more care, you may have to refer them to a lipid specialist or a dietitian. Just lots of things. Once you start getting into PCSK9 inhibitors, that's more for specialty practice. So once you're down in this level, this is specialty practice, cardiologists, lipidologists, those people. Lipid-lowering medication. Review the categories of medications used to treat elevated lipids. Know that cholesterol is manufactured in the body at night, and therefore most statins are given at night, with the exception, I've just listed two of them, there are others, that are Lipitor, Crestor. They can be given anytime. Two, they have a long half-life, so that's one of the reasons for that. Statins can be high, moderate, and low intensity, but the focus now currently is on moderate and high intensity statins. High intensity lower the LDL-C by greater than 50%, and moderate intensity lower the LDL between 30 to 50%. This is very important. You need to know this. Review some of the common side effects of the cholesterol medications. You want to make sure you've looked over those, and we'll go over that a little more. Remember to avoid statins in pregnant and lactating women. I can't say this enough. We used to do the categories. There would be a category, I believe, X. You do not give these to these women. Some people even give statins. You want to give them a few months, maybe. If a woman's wanting to get pregnant, also in women of childbearing age, if they need to be on the statin, you need to make sure they're on a very good birth control so that they're not getting pregnant, because you need to have a very candid conversation with them that you can't be getting pregnant on these medications. So make sure you've had that conversation. I can't stress that enough. Know that. Don't forget it. Know when their last menstrual period is. This for legality reasons and doing no harm. Avoid grapefruit juice while on statins. You can get into an interaction there with that, and so just you avoid that. Usually it only happens if you're in like a really high amount of grapefruit juice or eat a lot of grapefruits, but that's one that's always for all statins. Just avoid it. When combined with amlodipine, limit simvastatin to 20 milligrams a day. So this is one you would want to know specifically. It doesn't affect other statins that we know about, but simvastatin is one of them when combined with amlodipine. Well, a lot of people that are going to come into your practice are going to have hypertension, and hypertension that has to be controlled with a pretty robust blood pressure medicine like amlodipine. So often you're going to have them also on a statin. So when you have them on that, or they're wanting a med refill, remember this. Cholesterol is produced in the liver, and statins work by slowing down the production. So it does this following this little picture. If you look at it, reduced interhepatic cholesterol synthesis leads to the decreased LDL assembly. You also get reduced production of the beta-lipoproteins, reduced LDL-C and triglycerides with statins, reduced ApoB, and reduced non-HDL-C. We're going back here again with cholesterol synthesis. It's cyclical with the greatest production at night during the fasting states. And statins with short elimination half-lives are dosed at night, allowing for the greatest drug concentration. Those with long half-lives have flexible administration dosing. So let me just make a comment to you. I worked before populations where had a lot of casino employees or employees that work a lot of swing shifts or night. Remember, when is their night? If they're sleeping during the day, that may be different for them. So, that's when they're fasting. It might be during the daytime. So you may have to adjust when you would dose them and explain this to the person because, their nighttime might be at 8 o'clock in the morning when they're going to bed. So remember that. That's if you've got a shift worker who works third shift. Also, if you've got somebody who is taking Crestor or Lipitor, one of the longer acting medications, it has a long half-life. It doesn't have to be dosed every evening. It can be taken in the morning. Everybody agrees statins are the best for prevention of ASCVD. Okay, so there's no question about that. So you've got some questions to ask yourself. Who needs a statin? When do they need to be considered for a statin? And what type of statin do they need to be on? So those are questions you need to ask yourself when you're thinking about the test, when you're thinking about prescribing for patients, when you're thinking about certification. Those are things you're going to need to know. And here's the consensus statement of what all these experts, the ACC, the AHA, the NLA, these are all these experts on this. And this is what they finally came up with and decided. Okay, so look over this. Who gets a high intensity statin? Who gets a moderate intensity statin? Statin therapy is important. High and moderate intensity statins. You want to know this. You want to know that atorvastatin and rosuvastatin are your high intensity statins, but you need to know at what dose. They can be a moderate intensity statin if they're not dosed high enough. So make sure you know that. Know the other statins that are moderate intensity statins. Notes to providers on lipid medications. Labs, you want to obtain some baseline labs or lipid panels. Be sure to include triglycerides, HDL-C, LDL-C, and LFTs. Follow-up lipid panel in 6 to 12 weeks after starting statins, then for monitoring every 3 months to 12 months to monitor adherence. Repeat LFTs only if clinically necessary. Now this is controversial. We'll talk about that a little bit more in a minute. And CK or creatine kinase, you've got to check this if a patient comes in complaining of muscle pain. Now some people will just have a little bit of, yeah, I'm a little sore. But if they're really coming in, I am very sore. You touch them, they're hollering. They're miserable. Myopathy, they may be having some real muscle aches because of the statins. You've got to check their CK level, okay? So know that. Educate on risk. Now, this is, be sure to make sure you have put this in context. Greater than 7.5 is high risk, but this is relative risk, not absolute risk. See if the patient is willing to make lifestyle choices to reduce their risk and to make their health a priority. And I say this to you because, I've been guilty of this probably in the past too. I'm sure I have. When I talk to patients about their cardiovascular health and their health in general, I may come across, and I can see it on the patient's face, and then I have to backpedal. They may think this is absolute risk and not, you don't want to take away their hope. You don't want them to think this is permanent and that they can't make some of these positive lifestyle choices to turn things around, because they can, and you can help them, provide them with the tools. So that's what I want to convey to you when you're having those conversations with the patient. Make sure that you let them know these things are reversible. A lot of the stuff, some of it's genetic, some of it you can't do anything about. If they got familial hyperlipidemia, you can't change that fact other than you can treat them and dose them appropriately. But you can make a difference, and they can, and you can help cheerlead them sometimes when they need it and encourage them. Monitor for statin intolerance or issues. When you think about when they're coming in and they need a refill, or you've put them on something, you want to make sure if they are complaining about something, your HPI, you're getting a good history, or the review of systems, you're asking musculoskeleton, you got any aching, stiffness, tenderness, weakness, fatigue, cramps? That's what you got to have. Those are the questions you need to be asking on those people with statins. You need to make sure you're capturing that information. Other reasons for myalgias. Do they have hypothyroidism? Do they have a low vitamin D? Do they exercise all the time? I mean, are they new to exercise, and are they trying out for the triathlon, and maybe they've been a couch potato before? I don't know. Are they a heavy drinker? Now we've got a drug epidemic, an opioid epidemic. So there might be some other things going on there that you need to unearth and figure out what's going on that could be some secondary issues. So be aware of that. Fire and forget when treating dyslipidemia with statins. Gone are the recommended LDL and HDL, non-HDL cholesterol targets. Instead, the new guidelines identify 4 groups of primary and secondary prevention patients in whom providers should focus their efforts to reduce cardiovascular events. And the new strategy is fire and forget. And it's looked at this way. Number 1, you want to exclude remediable causes of secondary dyslipidemia, like we talked about, hypothyroidism, drugs, etc. Assess for risk factors that warrant lipid lowering and treat if indicated. Third, do not remeasure LDL-C unless results would alter management. Very controversial. Measuring lipid panels in 6 to 12 weeks could be helpful to ensure that you've got greater than 30% decline in the LDL-C and to check adherence. Periodic checking to monitor adherence could be useful. So you want to make sure that the statin you got them on is actually working for that patient if they are taking it. So there's arguments both ways. And now we've got the statin intolerant person. How do we define that? Well, this is what they say. Inability to tolerate at least 2 statins, and that can be one at the lowest daily starting dose and another at any daily dose. And if they have objectionable symptoms or abnormal labs due to statins. So if they've got LFTs that are 3 times their normal, that's usually considered, if it's 3 times above normal, yeah, you got a problem there. And if you have objectionable symptoms, well, if they have such bad myalgias, they can't work, or they're just in excruciating pain. You're almost needing to give them pain medicine because they're in that. That might be an issue. Or they're having diarrhea excessively, where it's inhibiting their ability to work. Those are, objectionable symptoms. they might not can tolerate this medicine. So think about that, because those things can happen, and they do happen. Example, patient unable to tolerate both Lipitor and simvastatin, developing severe myalgias. What to do if my patient is not tolerating statin? Okay, so how are you going to handle it? Because you will get this, and it will happen, even though they may need to be on it. You want to take a careful history of the myalgias. Make sure you're really dealing with myalgias. You don't want to have somebody who's a couch potato and all of a sudden they decide to get active because you were talking to them and you get them motivated to get off the couch. And so now they've decided to do CrossFit and they're sore as I don't know what, because for the first time in 10 years they've decided to get active. Well, maybe it's not the statin, and maybe it's they're finally finding they got muscles they didn't know they had. So figure out what you've got going on there before you jump the gun. Make sure you're really looking at what you think you're seeing is really what you're seeing. So take a good history. Consider secondary causes, like we talked about. Is there something else going on? Is there some, drug use? Is there hypothyroidism? Alcohol, whatever. Look and see vitamin D issues. Wash out and re-challenge. Take them off the statin. Take them off for a little bit. Few weeks, up to 3 months. See what happens. And then start them back. Start them back slow. You may start them back at a low, what would be considered low intensity dosing. You might start them back at only 5 or 10 milligrams of Lipitor. I've done that before and moved them up, even though that's not what's considered normal. You want to try to work them up and make sure you're identifying if they do develop a problem. So go slow. Go kind of that low and slow with it. Make sure. Consider changing drugs or dose alternatives. Maybe if they were on, simvastatin and you change them to Lipitor, or you go with something completely different, or pravastatin, go to a completely different one. Dose them differently. If you have one that has a short half-life, you go to a long half-life. You might dose them every other day. See what works. Be creative. There's some suggestions for this in your readings. When to consider a non-statin. Okay, non-statin options, ezetimibe, PCSK9, BAS, those are all options. And then there's the consensus statement on this. Usually ezetimibe is your first option as you go to, and you look over that. And then here's some information about your different statins and all your different cholesterol medicines, a lot of them, and kind of how they affect your LDL-C, your HDL-C, your triglycerides. When we're thinking about the different medicines, you want to know that statins, the most common side effect are your muscle aches, and that happens in about 10% of patients, okay? And they do have GI side effects. I mean, that is just a given. Statins are associated with about a 10% increase risk of diabetes, and other side effects are rhabdomyolysis and liver failure. Now, those things are rare, very rare, but it does happen. So you need to be aware of it. So when the patient comes in and they're talking about their aching, and they appear to be aching and uncomfortable, check that CK. All right, let's see. What else? Bile acid sequestrants, those are, that can be an option, but it can cause constipation. Some people don't like using that, but then that can be a positive if people tend to have a lot of loose stools, or you have some issue with that. Sometimes that can be just that side effect of constipation can be just what that person needs. So think about that with some of them. Nicotinic acid, Diaspan, causes flushing. That's kind of gone out of favor, not being used a lot anymore. Formic acid derivatives, you'll think about your Gemfibrozil, Tricor, very effective, helpful with your elevated triglycerides. So, you know, you'll see that you can, sometimes with that you'll have some cholelithiasis, so that might be a little issue there. And we'll go on to the next, PCSK9 inhibitors. They're approved and adjunct for diet in patients with ASCVD or familial hyperlipidemia. You may consider in a very high risk or truly statin intolerant patient. Typically lowers the LDL-C in patients on a maximum statin therapy. So these are for your people who can't tolerate a statin but desperately need to be on one, okay, or have familial hyperlipidemia. They're injectables given every 2 to 4 weeks. They're generally well tolerated, it's my understanding. They're majorly expensive. You'll have to have copay cards, have to get prior authorizations, not given really by usually people in primary care. This is usually you're going to be seeing a lipid specialist or cardiologist for this. Treatment for elevated lipids in kids. Lifestyle, recommended NCEP diet. Specifically the child 2 diet, child 1, the regular one, but when you have children that are really have major familial hyperlipidemia, the child 2 diet, but it's the NCEP diet. And you want to encourage regular aerobic exercise. Kids in general now aren't getting enough exercise. They're having too much screen time. So get them out and get them active is the big thing. Statins are FDA approved down to 10 in general, but pravastatin is approved down to age 8. Reportedly, they're well tolerated. In high-risk kids requiring treatment, usually they're referred to a lipid specialist or a pediatric cardiologist. Remember, don't give aspirins in kids because of Reye syndrome. Now, I forgot to mention this earlier, but you would give aspirin generally in an adult who is requiring a statin for cardiac more prophylaxis. So you would give that 80, you want to do 81 milligram unless there's some major contraindication. Triglyceride elevations. You want to always think with people that have elevated triglycerides, encourage good diets, decrease their carbs and their alcohol. These are 2 big things. Treat with meds when they get over 500 milligrams per deciliter. Fibrates are most effective. As I said before, Gemfibrozil is used. Elevated triglycerides is linked to metabolic syndrome. You'll see it in diabetics. You'll often see low HDLs and elevated triglycerides. So be aware of that. Also with high triglycerides, you're at risk for pancreatitis, so be aware. I put this slide in here, the ApoB, the apolipoprotein B, just so you would be aware of it, because you might see this in a cardiology practice or a lipid practice. You won't see it as much in regular primary care, maybe in internal medicine if you're doing, if you've got a lot more high-risk patients, and depending upon what the insurance will pay for. Apolipoprotein B, The ApoB is a protein that is involved in the metabolism of lipids and is the main protein of VLDL. It binds lipids to form lipoproteins and functions to transport lipids, fat around in the body. ApoB level is used to evaluate cardiovascular disease and is thought to be a better predictor of heart disease risk. Reference range is adjusted based on risk stratifications. Normal, 40 to 120. Less than 100 is desirable. Less than 80 is preferable, particularly in high risk, like your diabetics. ApoB and non-HDLC are better predictors of ASCVD risk than LDLC. Treat the patient to goal level first, better marker for monitoring patients on statin therapy for residual risk than LDLC in the highest risk patient. Using some settings to assess risk in diabetic and metabolic syndrome patients. They tend to have small, dense LDL particles with relatively normal LDL-C, but high ApoB levels. This is another way of picking up additional risk when you think you've got them treated, but maybe you don't have them treated as well as you would like, and they don't have to be fasting when you draw it. This slide is old, and it doesn't have all the latest and greatest, but it does give you some of the common side effects of a few of the medications. The biggest thing is know the side effects, the major side effects. I have this slide in here just to get you to think about it, since statins are primarily what is prescribed for lipid dyslipidemia. Although statins are recommended and prescribed, there's often poor compliance and adherence. And I want you to just look at this. Statin compliance over time. If providers prescribe it 100% of the time, when according to evidence-based practice, what should be done, patient gets the prescription, or the prescription is sent to the pharmacy. Patient goes, only 88% of them fill it. Only 76% of them then start it, and only 47% actually take the medicine and take it like you would think they would be supposed to. Why? Common barriers: forgetfulness, side effects, financial, polypharmacy. They require ongoing reinforcement of why. Because people don't have symptoms with elevated lipids. It's not like you feel bad. You don't feel anything until you have a heart attack or a stroke. So we need to encourage our patients. So think about that and kind of cheerlead them. Leave you with a parting thought from the mother of nursing. As you go forth and try to do good things to people and encourage them. Apprehension, uncertainty, waiting, expectation, fear of surprise do a patient more harm than any exertion. Florence Nightingale. So go forth and try to do good things out there, because there are a lot of people that need you. Take care.